I am your host, Deborah Foreman, the Educational Programs Coordinator for MS Focus, and I am joined by Dr. Ben Thrower, who's going to be answering your questions during our town hall style presentation today. Unlike our usual style, where we open up for questions and answers after the speaker presents their topic, today the entire hour will be open for questions and answers. You can either raise your hand in the app to tell me you have a question, or you can let me know by typing your question in the chat box. If you want to speak out loud, then I'm going to have to unmute you, and you will have to allow me to do that when I ask you. So now I'm delighted to introduce our speaker. Dr. Ben Thrower, as most of you know, is the medical director of the Andrew C. Carlos MS Institute at the Shepherd Center, Atlanta, Georgia. He previously served as the medical director of the Holy Family MS Center in Spokane, Washington. Dr. Thrower is a senior medical advisor for the Multiple Sclerosis Foundation and enjoys contributing to their quarterly Focus magazine. When Dr. Thrower isn't dressing up as Jack Sparrow, which is quite often, I believe, as a pirate, he can also be found playing with his grandson, Sam, who I used to say his new grandson, and he's not so new anymore.
Not anymore.
So I know. Anyway, I'm delighted to have you today to speak and to talk to everyone. So why don't I turn it over to you, and we'll see if people have questions or if you have anything to say at first.
Great. Well, thank you. Thanks, Devin. Thank you to all of the folks behind the scenes at MS Focus. As always, we appreciate everything you folks do. So as we kind of get into the questions, just one reminder to our folks who are on the line with us, try to keep the questions kind of general. Just not, what we don't want to do is have people go too far into their own life story. Everyone, has their own unique situation with multiple sclerosis. It's been said that if you've heard one person with MS's story, you've heard one story. Everyone's different, but we want to try to get to as many questions as we can. So try to keep your questions really focused and on point.
Let's see. Okay. So we have a question from Facebook. Brenda has, whoops, where did that go? Let's see. Okay. Brenda has asked, in reference to MS and COVID, I'm currently on Ocrevus. Does MS put me at a higher risk for becoming infected with COVID and higher risk for having a bad case of MS?
So realize that what we understand with COVID is evolving every day. And the Delta variant that is the major culprit for most infections we're seeing now is a different animal than the original ancestral version of COVID in the early on in the first wave of the pandemic. So we do have to think about the different therapies with multiple sclerosis. The National MS Society has commented that drugs like Ocrevus, the B-cell therapy, so this would also include Rituximab, Kesimpta, Rituximab, that these drugs could potentially be associated with a higher risk of hospitalization from if you were to get COVID. It's very, very important that you have a discussion with your healthcare team about the risks and benefits of remaining on Ocrevus and what appropriate labs need to be done. Most MS centers are very vigilant about monitoring immune function for patients on Ocrevus and similar therapies. So we want to make sure that the Ocrevus is doing exactly what it should be doing to your B cells and not hitting other parts of your immune system. So MS by itself, if we put the therapies aside, does not put you at higher risk for having a bad outcome or a hospitalization or death with COVID. It really is more the therapies that you're on, and then any other potential health conditions that you might have. So again, talk to your healthcare team about what sort of monitoring you're getting. There are certain individuals that maybe we want to think about modifying their Ocrevus therapy. For instance, if I have a 70-year-old person with primary progressive MS, do we want to talk about maybe holding their Ocrevus or delaying it or maybe discontinuing it altogether? That's a very different discussion than, say, a 30-year-old with relapse and remitting MS, where we would be a little less excited about changing their therapy.
Okay, Great. We have another question also from Facebook. How long should an MS patient be under Tysabri?
So there's no time limit on how long you can remain on Tysabri. A lot of people get hung up on the 2-year time mark because that's when the risk of PML could change if you have higher JC virus antibody index titers. So as long as we're monitoring your JC virus antibody index and you're in a low risk group, for us, what that means is a JC virus antibody index of below 0.9, there is no time limit on how long you can be on Tysabri. We check that JC virus antibody titer on an every 3-month basis. Some centers do every 6 months. And as long as it's staying in that safe range, there's no time limit on how long you can be on Tysabri.
Right. If someone loses their mobility in their legs, this is from Kim, can that mobility return with regular exercise or will the loss be permanent?
So there's always the potential for regaining function in multiple sclerosis. Generally, if a person has had a particular challenge, let's say mobility issues, weakness in their legs, for more than a year, the likelihood that it's going to return is not great. It's never zero, though. And we do see individuals who do regain some function even after a year after a relapse. So the other part of that is, how much of that loss of mobility and weakness could be deconditioning, how much of it is spasticity. We're big believers in rehabilitation and exercise. So if the person's not been given a course of aggressive rehabilitation, I think that's really important. And maybe what we're thinking is weakness could actually be spasticity, and we manage the spasticity and maybe the person functions better. So we never say never. We always keep our eye on the future for repair strategies that are hopefully, going to be a reality someday. But again, I'd like to emphasize the importance of rehabilitation and exercise.
Okay, Juan is having trouble recovering from his last flare-up where he had a bad fall and his left, let's see, where my left doesn't bend up to his shin. I guess his leg doesn't bend up to his shin. So I think that's probably a question in there.
Yeah. So early on after a relapse, one of the questions is steroids or not. So, the standard course of steroids in the United States is going to be 3 to 5 days of Solumedrol. And what we think is that that's going to speed the recovery. It's questionable as to whether it changes the ultimate recovery. Some would say it doesn't really change the ultimate recovery, just gets you there faster. But what research has also shown is that if you have a significant relapse and we throw rehabilitation in with the steroids or not doing steroids, that we do improve the recovery. So rehabilitation, again, I'm going to sound like a broken record to a certain degree on some of these questions with emphasizing rehabilitation. We want to make sure that we've really pushed the physical and, if necessary, occupational therapy aspects of that to really try to make sure people regain as much function as they can. And if we don't regain it, how do we adapt to it? So if someone needs something to help with foot drop, for instance, foot drop is one of the most common gait difficulties we see in MS, and is probably one of the most undertreated gait difficulties. There are things we can do. We traditionally think of things like ankle foot orthotics, but there's a ton of other stuff out there. If someone doesn't like an ankle foot orthotic, we have the functional electrical stimulation devices like the Bioness devices that can be amazingly effective in the right individual.
Okay. Elizabeth would like to know, should we have MRIs that assess brain volume? Her radiologist said that the technology isn't accurate.
Yeah, so we know that brain volume is very important, that one of the correlates of disability in MS is loss of brain structure. So we can talk about whole brain volume, we can talk about loss of volume in specific structures like the thalamus, and we know these things are important. Research tells us that they're important. Her radiologist comment, though, is also correct. Are we good enough to measure them in the clinic yet? Maybe not quite yet. We do it at Shepherd Center. We use a system called NeuroQuant, which gives, volumetric measurements of different brain structures. I think the science is not quite decided on how accurate that is. These are computer-based programs. So usually there's no charge to the patient, but they do cost something on the end of the radiologist to purchase these programs. So we know it's important, but I kind of agree with the radiologist. I'm not sure we're quite ready for prime time yet in the clinic.
Casey, I just lost my screen for a moment. Can you read the next question while I'm figuring that out?
Yeah, absolutely. Give me a second to get there. I've been switching back and forth to support our Facebook folks. All right. Let's see. Judy Betts asks, what is research showing in women over 60 with RRMS or active progressive MS and its success in reducing further disability and or lesions?
So she asking the age factor, was that the question?
Judy, can you raise your hand and let's have you clarify that? Do you mind? All right, I've given Judy the option to unmute and ask her question.
Yes, hi. Am I on mute? Am I unmuted?
You sure are. Go ahead.
Okay. I'm sorry, I forgot to type in if you're on Ocrevus.
There you go. So if we put the gender part aside for a second, when we look at just the age factor, so as we get older as humans, we do go through something called immune senescence. Our immune systems mellow out, and so it's less likely to see angry inflammation in the brain or spinal cord in, say, a 70-year-old than it would be a 30-year-old. And so we do think that as we just mature as humans, there is probably a point where people can come off of their disease-modifying therapies. The kicker is there's a wide range of human experience in there. And so we see 70-year-olds whose brains still think they're a 30-year-old and they're still generating active inflammation. We see 62-year-olds who probably could come off their treatment. The challenge is we don't have a biomarker. We don't have a blood test that would let us say, you're ready to come off of your treatment. So there is a lot of educated guess and a lot of discussions about risks and benefits with individuals. And ultimately, it comes down to what the person with MS and their family is comfortable with. I never want this to be hopefully a financial decision. Sadly, sometimes that does factor in. Sometimes it has to do with convenience. I think with Ocrevus, the other thing that has factored into that discussion is COVID now. And so, if we have, say, again, a 70-year-old, what's their risk of getting really sick with COVID? And are we changing that risk with their Ocrevus versus what's their risk of their MS flaring up if we stop the Ocrevus? There are a lot of moving parts in that discussion, but it is something everyone's very interested in.
Thank you.
Yeah.
Thank you. Jennifer says that she takes baclofen 4 times a day and a pump has been recommended. Would you please talk about how it works and if both upper and lower extremities with one pump?
So when we take baclofen by mouth, baclofen is our old standby. It's our oldest medication that we use for spasticity and MS. So when you take baclofen by mouth, a certain amount is going to go through the liver. It's eliminated. It's metabolized. A certain amount gets into the central nervous system. Part of baclofen, when we take it by mouth, goes into the brain. That is not where we want baclofen working. That's where you get your sedation from. So if we could bathe your spinal cord with concentrated liquid baclofen by putting it into your spinal fluid, in theory, you get all the good without the bad. You're having it work exactly where it needs to work. It's not getting into the brain itself, it's acting at the spinal cord. You can get away with magnitude lower doses because you don't have the liver metabolism coming into play. So by putting a small pump in, it's about the size of a hockey puck, just under your skin, on your flank, and then having sort of tubing running into the lower back to deliver that concentrated liquid baclofen into the spinal fluid. Again, hopefully you're going to get the good without the bad. It's a surgery. You want to know that it's going to do what you want it to do before you have that surgery done. So there's a trial. They can either do a one-time test dose of the liquid baclofen by a spinal tap, or they can put in a temporary 24-hour pump and let you actually get up and move around with it and see if it does what you want it to do. It tends, the intrathecal baclofen or the baclofen pump tends to work better for leg spasticity than it does for arm spasticity, and that's just a simple factor of gravity. You know, the baclofen is going to tend to be in higher concentrations in the lower part of the spinal cord that affect the legs more so than the arms. That's not to say it can't work for the arms. It's just you're gonna get a little more bang for the buck with the leg spasticity. These pumps hold about 3 months worth of the baclofen. You go back in every 3 months. It can be accessed just through an injection. They can access that port, refill the baclofen. The pump can be adjusted through a laptop computer with a security code and a magnet, so that the dosing can be changed just through the secure computer system. The pumps are MRI compatible. Every time you have an MRI, you're going to want to have that pump checked to make sure it's still, that the magnet didn't change the settings in any way. We call that interrogating the pump. So you get your MRI done, the technician's there or nurse, someone's going to know how to do that and make sure the pump is still operating effectively.
Interesting. Crystal was diagnosed in 2020, and she said that she's on Avonex, but she has a feeling of something crawling in her brain. Her neurologist said lesions don't hurt. And then she wants to know, well, what am I feeling if that's not the case?
So our brain is actually incapable of feeling anything. So when we feel something in our head, our scalp, our eyes, we're feeling it at the peripheral level. So the sensation you're having is very real, but it's not actually you're not feeling it in the brain. The sensation is there. So it's very likely that there could be an old MS lesion that is altering your sensation and giving you that feeling. MS is notorious for throwing weird feelings at people. It'd be enough if it just caused plain old boring numbness, but it doesn't do that. It causes extra feelings. And so some of the extra feelings that people report are, there's water running on a body part when there's really nothing there. There's a bug crawling, there's nothing there. There's a hair somewhere, there's nothing there. Unfortunately, sometimes these extra feelings get painful. You can have electric shock sensations, or you can have a burning sensation or hypersensitivity. So all of these are just some version of altered sensation from your MS. But your neurologist is right. You're not feeling the lesion itself. You're feeling kind of what the lesion is doing and altering your sensation.
Okay. And Michael has not told me anything about himself, but he does want to know, should he get vaccinated? So it's kind of a general.
Yeah. So I think in general, yes. So we know that the vaccines are safe for people with MS. The National MS Society put a panel together back in January of 2020, and I'm sorry, 21, and looked at this. It was a panel of epidemiologists and virologists and epidemiologists. So early on, we speculated that these vaccines look safe. Well, we don't really have to speculate now. We've seen what the vaccines look like in the real world for people with MS. For instance, here we have about 700 people with MS who've been vaccinated, maybe more. These are the people that we're aware of. And we've not seen people with MS behaving any differently than the general population with their vaccines. Generally, I'm more in favor of the Moderna or the Pfizer vaccine. I just think they're more effective than the Johnson & Johnson. If Johnson & Johnson is what the person has access to, I'd be in favor of that over nothing. Again, this Delta variant is different. It is magnitudes more contagious than what we had before, and it seems to be affecting primarily unvaccinated people. Vaccinated people can still get infected with the Delta variant, but they tend to not get ill with the Delta variant. So I think to protect yourself, unless you've got some wonderful medical reason to not get it, I would say get it.
And Jason said, any suggestions for getting buy-in since insurance doesn't like to approve it?
Yeah, that's very frustrating. I can tell you what we do here locally, and I think other places could potentially look at this as a model. The buy-in units are FDA approved for MS, and it's very frustrating that insurance is not covering them. So we found a very kind donor here in the Atlanta metro area who actually stepped up to the plate. And if insurance denies an individual, we do a sort of a financial sort of checkup. We have an algorithm that we use. We look at how much could the person with MS actually afford to contribute. It may be 20%, it may be zero. And then we go to that donor to see if they will actually pay for them. That's the route we've gone. I think sometimes MS communities do have to sort of think outside the box, become your own advocates and say, listen, if my insurance company is going to be a pain in the butt and not cover these things, let's through our MS center or through whoever establish some funding so that we can help get these things covered.
Bernardo's asked, should patients on Ocrevus who did not make antibodies in response to COVID vaccine treat themselves as unvaccinated for public policy purposes?
Yeah, that's a great.
And in other words, without COVID antibodies, we are vectors for COVID transmission. Shouldn't we make up and take other precautions, not only to protect ourselves, but to protect others? And if so, are there mechanisms for communicating advice this more broadly to Ocrevus patients?
Yeah, that's a great question. And so this is unpublished data, but what we know is that about 50% of Ocrevus and Rituximab patients are not making antibodies to COVID vaccination and probably to COVID infection as well. That doesn't necessarily mean they don't have some degree of immunity. The same study found that almost everyone on Ocrevus made a great T-cell response. And so you can have immunity to COVID or after infection or after vaccination through both B and T-cell pathways. We don't know which one is more important. Is it 50-50? We just don't know that. But clearly, people on Ocrevus do still make a T-cell response. So they do have some degree of immunity. Because we don't know how much, I think the second part of this question, no one's been hurt by wearing a mask. And so I think, just acting as if you are infectious, because we know even vaccinated people with a normally functioning immune system do get Delta and do potentially transmit Delta. The thing that makes Delta different is the original ancestral version of COVID was largely in the bloodstream and in the tissues. This Delta version seems to set up shop in the nasopharynx. It's right here. Our vaccines don't seem to offer a lot of protection against right here. So our vaccines are going to keep vaccinated people from hopefully getting ill, but they may still let the Delta variant grow here so that you could transmit it to other people. So you could argue that maybe we should all be acting as if we're potentially, infectious to other individuals, but maybe even a little bit more so with the Ocrevus patients. I think how we transmit that information, I think it's a big challenge. There's been such a moving target with what we know and don't know and what information changes with COVID. I think the changing landscape of our knowledge is part of what has led some people to be untrusting of different sources and say, they told me this last month and now they're telling me this. That's because everything's changing. Again, this Delta variant is not the same, virus that it's the same. It's a mutation of the same virus, but it's acting very differently than the original version.
Good answer. Okay, so Sherry said that you mentioned steroids to treat MS relapse. Could you address when they might not be appropriate and how high use over the course of disease,
Yeah.
age, gender?
So steroids, always come with some risk. And so there are people who probably should not receive steroids for MS relapses. So if you have a history of poor tolerance for steroids, some people get energized with a 3-day course of steroids. Some people become outright psychotic with a course of 3. That person should probably not get steroids. If you have tightly controlled diabetes or tightly controlled hypertension, I think we really need to think about the risk of the steroids. We know we will raise your blood sugar when we give you a course of steroids. In the back of our mind is always this thought too, that the steroids are going to make you better faster, but you are likely still going to recover to the same degree. So is it okay to just wait out the relapse, pursue rehabilitation, do whatever else we need to do and not pursue the steroids? With steroids over time, we do run the risk of, again, bone thinning, risk of osteonecrosis. So the femoral head, the top part of our femur, the hip bone, can become damaged and actually kind of crumble. And that's obviously not a good thing. More dental problems in people that have received steroids over time. And we see people that end up having a lot of tooth extractions and root canals from steroids over time. One individual's tolerance for steroids may be very different from someone else's. So we see individuals who've had tons of steroids over their life and seem to get away with it. Other people get 3 courses of steroids, for relapses over a few years and end up with a femoral head problem that requires surgery. So again, we shouldn't take steroids lightly. They can do good things, but they also come with some potential risk.
The age and gender wouldn't be a big concern, or would it?
Gender, in that women are more at risk for osteoporosis. So if you have a female who already has bone thinning just naturally from their osteoporosis, I'd be a little less excited about treating that person with steroids. Age, again, osteoporosis becomes a little more common as we get older. There could even be racial differences. We know that, for instance, African Americans tend to have a lot better bone density sometimes than other groups, so they might be more tolerant to steroids from a bone density standpoint.
Interesting. Tony said the COVID vaccine says it isn't as effective in people who are immunocompromised. Is that true? What is still the best option for us, people with MS, then?
So first point I would make is that put the MS therapies aside. Let's just talk about a person with MS. People with MS are not immunocompromised. Your multiple sclerosis by itself gives you an overactive immune system, not an underactive immune system. And that's a common myth that we hear. Even in people who've been dealing with MS for years, they're under the mistaken impression that they are immunocompromised from their MS. Not true. So if we're just talking about MS, people with MS really don't have by itself, no other health problems, no medications considered, really don't have a higher risk of getting sicker with COVID. Now we throw the medications on board, and then we have to ask the question, have we immunocompromised you with your medications? Certain of the drugs, no. So our old interferons, COPAXONE, those do not compromise the immune system. Tysabri very specifically blocks the ability of inflammatory cells to cross into the brain and spinal cord. I don't think of a Tysabri patient as being immunocompromised. If we're on Ocrevus or an S1P drug like a Gilenya, Mayzent, Ponvory, or Zeposia, those drugs do alter the immune system in a way that you could say, yeah, maybe that person is mildly immunocompromised and could potentially have a different response to the vaccine. Maybe they're not making as much of an antibody response. But again, we have to realize there's another part of the immune response to vaccination or infection. It's the T-cell response. We do have a blood test to measure the T-cell response to infection or vaccination. The problem is it's not user-friendly. There's only one company in the country running that blood test, and it's not very accessible. To my knowledge, insurance is not paying for that T-cell test. So I know in our center we've not been using it just because I don't think it's very practical at this point.
And Sharon would like to know, out of Ocrevus and Mavenclad, out of those two, in your opinion, which is having better results with SPMS?
So realize that when we talk about SPMS, we changed the nomenclature a little while ago. So we used to just talk about relapsing remitting MS and secondary progressive MS. Now we've divided secondary progressive MS into with and without activity. With activity means you still have relapses, or you have new lesions on MRI, or you have both. Before we changed the nomenclature, we would have probably labeled that person who has active secondary progressive MS as really having relapse and remitting MS. The secondary progressive MS without activity is more the traditional classic secondary progressive MS. No relapses, no new lesions on the MRI, just kind of progression of disability. Technically, our drugs that are getting approval for secondary progressive MS are for that active form. We really don't have a great disease modifying therapy for secondary progressive MS without activity. The MS changes from an inflammatory condition to more of a degenerative condition, and most of our therapies, Mavenclad and Ocrevus included, are targeting inflammation. And if that target's not there, it's really hard for the drug to do much. So there's never been a head-to-head study of Ocrevus versus Mavenclad for pure secondary progressive MS. Ocrevus does have FDA approval for primary progressive MS, and some people have said, well, it's primary and secondary, they kind of overlap a little bit in terms of their pathology. Maybe if Ocrevus works in primary, it might do something in secondary. I don't know that we've proven that. So I think what we're left with is trial and error, honestly, to see which is going to be a better fit. I think Ocrevus and Mavenclad are both great drugs. They have their own niches. They're unique. They're very, very different medications. And I think that's going to be a discussion with your MS team to see which is a better fit for you in that given situation.
Okay, and I know Tony had asked you a question about the immunocompromised, but he also said that he feels much better when he's on a low dose of prednisone. Is this ever just a treatment option?
We hear that a lot. And so it's hard to know when people, that's a real thing. So people do feel better on a little bit of prednisone. It's hard to know why people feel better though. So if a person without MS starts, say, a Medrol dose pack, a lot of people feel good. They're energized. They've got energy. Not sure why. What is it that we're really treating when we do that? So I'm not sure the low-dose prednisone is really doing something good for the person's MS. And again, it clearly can do some bad. So that's going to be an interesting discussion with his neurologist to say, okay, is the good feeling worth the risk? And does Tony have any other health issues, hypertension, diabetes, osteoporosis, that would make staying on that low dose of prednisone forever a bad deal for him?
Sharon said that she asked if you're familiar with any patients who have the baclofen pump whom are still walking. Have you seen the benefits? And she said she suffers from severe lower limb spasticity.
So we used to think of the baclofen pump as something that was last resort. You've tried everything humanly possible, and now you're going to pull this out of the toolbox. And a lot of the individuals that ended up with baclofen pumps were non-ambulatory. So you had patients who, people with MS who were in scooters and power chairs, manual chairs. That idea has changed. Now there's a move toward maybe using it earlier in people who are still ambulatory. So I think, an ambulatory person is still could be a fine candidate for a baclofen pump. It's really a matter of saying, okay, what's in my toolbox? So when we think about the pyramid of managing spasticity, the first level is remove noxious stimuli. If the person is having UTIs, anything else that's driving their spasticity, get rid of that. Then it's rehabilitation, physical therapy, stretching, and more stretching. Then your oral medications, your baclofen, your tizanidine, Now I would say your cannabinoids are in there also. So, whether it's some form of medical marijuana, we're in the testing phases of Sativex right now, which will be the FDA approved version of medical marijuana. And then your kind of your notch up from that is going to be intrathecal baclofen pump and Botox somewhere in there, depending upon what muscles are spastic. Maybe we're moving the baclofen pump kind of lower into that pyramid and thinking about it a little bit earlier now.
Ronald's asked, is there a better product to promote regularity than psyllium?
So with, bowel function, so, again, I think kind of pyramid. So we want to think about the basics, hydration, and then exercise. And so, Tracy Walker, one of our nurse practitioners here, was famous for saying, if you don't move, you don't move. So you've got to keep moving or you're good, because the more sedentary you are, the less regular your bowel function is. So hydration, exercise. I usually then look, and some people, at a fiber supplement, and then Miralax. Miralax is probably the best over-the-counter product that we've got out there. Stool softeners, Ducalax, Colace, things like that are fine also. Sometimes then we get into, either things like periodic enemas, and then also looking at what medications the person's are. Are we worsening the constipation by using things like some of their bladder medications? Most of our bladder medicines, our Detrols and Ditripans, can worsen constipation. Do we need to think about getting the person off of that and onto a medicine like a Myrbetriq, for instance, where there'd be less of that potential for constipation?
Karen said that she is on Kesimpta. How can she find out if she has COVID antibodies from vaccination? She had a SARS-CoV-2 test, which came back negative. 0.6 was the value.
So that is the COVID. So she had the COVID antibody test. And so again, what we're finding is that she's in with about 50% of individuals who have been vaccinated and they're on a B cell therapy and they didn't make antibodies. But again, she may still have an immune response through those T cell pathways, totally unrelated to her antibodies. And those T cell pathways should not be affected by her Kesimpta.
Okay. Marie wants to know, what do you do if you can't breathe in a mask and you almost pass out each time you wear one?
Maybe try different masks. Here in the hospital, in most hospitals, we're using KN95s, not N95s. The KN95s, the airflow is a little bit better, and you have almost the same level of protection that you do with an N95. I suspect at the end of the day, there will be individuals that, for whatever reason, just cannot mask. And so then you're going to have to look at other mitigation strategies. How much do I just stay away from individuals? I think a good face shield. So you're trying to keep large droplets out of your eyes, your nose, and your mouth. A mask helps. A face shield, that's going to not restrict your airway at all, and it's still going to offer you some protection. It's better than nothing.
Deborah said, is there any MS med that helps with blurry vision? She has relapse remitting and am on obagio for almost 3 years.
So with visual changes, we really want to make sure the person has seen their ophthalmologist recently to make sure that we're not blaming the MS inappropriately. So any visual change that's refractable, if we can put a lens in front of your eye and make your vision better, that's not your MS. And then the question is this old optic neuritis that's giving you blurry vision, could it potentially be double vision mimicking blurry vision? So if you have your eyes not tracking perfectly, you can get sort of a ghost image that could look like blurred vision, and there could be a treatment pathway for that. If in the end it truly is blurred vision from old optic neuritis, unfortunately, there really is not anything we can do to restore that right now. I do think we are getting closer to the idea of neural repair. And when you look at strategies and research options that are focusing on repairing damage, A lot of times they're using old optic neuritis as their model, not because we think that's the most important thing, but it's probably the easiest thing to study. Vision is so objective, and so if you improve someone's visual acuity with a repair strategy, you're going to know that pretty early on. We can measure it. We can do something called OCT, where we measure the thickness of your retinal nerve fiber layer. We can look to see if a research option might actually improve that retinal nerve fiber layer. So if her board vision is her MS, we may not have anything in the toolbox right now, but I do think in the future we may well.
Thank you. Let's see. We have a question, and I don't want to pronounce her name wrong. Christian, I think. I'm sorry that I screwed that up, but she's asking if you can talk about techvidera and the PML danger.
So techvidera, and now there's the generic forms, the dimethylfumaric acid. There have been cases with PML and that drug. Every case of PML with techvidera was associated with low lymphocyte counts, or when we break the lymphocytes down into the subsets CD4 and CD8, either the CD4 was very low or the CD8 was very low. My feeling with techvidera is if we monitor those things appropriately, we should be able to, if not completely eliminate, largely eliminate the risk of PML. So if we're following the total lymphocyte count, I get nervous when someone's lymphocyte count starts, dropping into the 800 range, on a drug like techvidera. We personally like to do what we call T-cell subsets. We like to break those lymphocytes down into CD4 and CD8 counts. We found a small population of people on techvidera who had a total lymphocyte count that didn't look so bad, but when we broke down the subsets, either their CD4 or CD8 was lower than we were comfortable with. So again, it's harder with techvidera to give an exact numeric PML risk as opposed to, say, Tysabri, where there's a lot of data. But again, if you follow those lymphocyte counts and the T cell subsets, the CD4 and CD8 counts, you should be able to largely eliminate that PML risk.
And Dr. Throw, this is a little bit more of a personal question that you might be able to give a general question, a general answer if you can try, but it's from Zara. They said, I have strong MS and it's affected my eye, and now I have foot drop, but the doctor in Iraq gave me Rituximab instead of the Tysabri. Is that right? And what about Ocrevus? Would it work with me? So
when you look at the most effective therapies, when we look at MS, really it's your infusion. So you've got Tysabri or natalizumab. You've got your B cell therapies, and so Rituximab, Ocrevus, ocrelizumab, and Kesimpta are all B cell therapies. And then you've got Lemtrada is another infusion. I don't think of Rituxan and Ocrevus as having any difference in effectiveness. We still have a ton of patients on Rituximab. We like the drug. Some of our insurance carriers have actually mandated that we use Rituxan or the bioequivalent Truxima over Ocrevus for cost reasons. Those two drugs are magnitudes cheaper than Ocrevus is. I'm perfectly happy with Rituxan as an option as opposed to Ocrevus. They do exactly the same thing in your immune system. They're both B cell therapies that work on what we call CD20 cells. So I'd be perfectly happy. Rituxan / Ocrevus versus Tysabri is a whole different discussion. These drugs have very different mechanisms of action. It's not that one's better than the other. They've never been compared head to head. My gut feeling, working with people with MS, is that I feel like Ocrevus / Rituxan and Tysabri are very, very similar in their effectiveness.
thank you. Lisa would like to know what your opinion is about COPAXONE.
COPAXONE is one of our original three, drugs. The COPAXONE is hands down the safest MS therapy we will ever have. I think that's one of the things it's got going for it. It is the only MS therapy that we don't have to do any laboratory monitoring. there is no potential for us to compromise a person's immune system with COPAXONE. It's a modestly effective drug. There are people that do fine with a modestly effective drug. We know from back in the days when all we had was ABC, Avonex, Betaseron, COPAXONE. We had individuals who were stable as a rock on COPAXONE. So if someone is on COPAXONE or Avonex, Betaseron, Rebif, and they've been on the drug for years and they're doing great, I don't, unless they come back and say, I just can't do shots anymore. I'm tired of this. What else you got that's not a shot? If their MS is stable, I don't feel the need to change them just because something else is better on paper. If you're getting an A+ on your MS exam, meaning no relapse, no progression of disability, no new MRI lesions, if by every measure we have, you're stable on an old therapy, there's nothing to say you have to move to a newer therapy just because that newer therapy looks better on paper.
Great. Sharon has an interesting question. I see a huge relief in my spasticity from day 1 through 14 of my cycle. Are you familiar with any cases where spasticity is related to hormones?
So spasticity is the most stimulus responsive symptom I think we see in multiple sclerosis. Maybe fatigue is right after that. So by stimulus responsive, I mean what's going on in your body in your life can have a huge impact on how bad your spasticity is. So you name it, and we've heard people say my spasticity gets worse when I do X or when X is going on in my life. And I don't think it's a stretch at all to say that hormonal fluctuations could be one of those stimuli that could change. We see people whose spasticity acts up if they're a day late on their bowel movement. We see people that have a poorly fitted ankle foot orthotic that's rubbing their ankle a little bit and their spasms go nuts when they wear that ankle foot orthotic. Urinary tract infections, upper respiratory infections, sleep deprivation, stress, cold. So a lot of people with MS are heat sensitive. Some people are cold sensitive. And if you have a person with MS who's cold sensitive, usually it's their spasms and spasticity that act up when they get chilled. So no, that's not a crazy story at all.
So Marlene would like to know your thoughts on Kesimpta. Her son has been on Tysabri for 6 years, and now doctors moving him to that Kesimpta.
Yeah, Kesimpta is a great drug. I mean, so again, it's in that B cell therapy class with Ocrevus and Rituximab. I would expect that it's going to be just as effective as Ocrevus and Rituximab. It adds, the benefit of people being able to do it on their own at home, once a month subcutaneous injection. I think one of the things that's really, really important with Kesimpta, because now we're saying, I'm taking it out of the hands of my infusion nurses. You're not coming in to get your infusion. You're not getting your labs drawn with your infusion. Don't miss your appointments. Make sure you're showing up for appointments, that you're taking your drug on time, that you're getting your labs drawn on time. I do worry a little bit about my Kesimpta folks if they were to miss a 6-month follow-up and now they've gone a bigger block of time without having safety labs drawn. Are they out there in the community with maybe a low immune system that we're not aware of because they didn't get their labs drawn? So great drug, just make sure you're getting your safety monitoring done.
Good point. Lourdes would like to know, it's going to open up a can of worms, but she'd like to know, is cannabis a good treatment for MS?
So cannabis is a good tool in the toolbox for symptom management. So think of cannabis as something that you could use to manage certain symptoms. It's enticing to think of cannabis as being anti-inflammatory. There's a lot of basic science that says it is, and therefore could it actually change the course of MS like a disease-modifying therapy? It's interesting to think that it could. No one's proven that it can. So I think for right now, we think of cannabis as a symptom management. And the 3 symptoms that seem to be potential targets for cannabis would be spasms and spasticity, central neuropathic pain, burning, hypersensitivity, and maybe urinary frequency and urgency. So yeah, I think cannabis is a tool in the toolbox for managing any of those symptoms.
Brenda would like to know, are there any contraindications for someone with MS taking Ocrevus if they're taking Wegovy for weight loss?
So none that I've seen. We have had a few patients, that are on, the different therapies for weight loss. One of the questions that comes up is, if you have a treatment, let's say for a migraine drug, like that's also a monoclonal antibody. So Ocrevus is a monoclonal antibody. A lot of these other new therapies that are coming out are also monoclonal antibodies. And so, from what we've seen, there's no contraindication between using two different monoclonal antibodies. So no, I am unaware of any contraindication between those two drugs.
Karen would like to know if you have the name of the lab that tests T cells.
It's called TCELL. I'm just going to turn this off for a second. It's called TCELL Adapt is the company that does that.
Okay. Mary would like to know, are there any current recommendations or thoughts regarding booster shots for those vaccinated MS folks approaching their 6-month anniversary from second Pfizer shot?
Yeah, that's obviously the $1 million question for all of us, and hopefully we're going to get some clarification on that, soon. We just don't know. I think right now the weight of the evidence says we probably are going to be doing boosters. If you ask me right now, for myself and my family, so we were vaccinated back on Christmas Eve 2020. Come November this year, if I was offered a booster, would I do it? Yeah, I think right now I would. We'd like to see boosters maybe start taking into account potential variants down the line. As if God forbid if COVID throws another weird variant other than Delta at us, there are targets that we could potentially work on other than the spike protein. So everything we have right now as a vaccine is based upon the spike protein. That's what the COVID is mutating. If we could have another target for COVID that doesn't mutate, that would be really appealing. And so if we could get a booster that targets something other than spike protein, or a vaccine that targets something other than spike protein, I think that would be ideal. So honest answer is we don't know yet, but I think there's a high likelihood that we're probably going to be doing boosters in the fall and winter.
Elizabeth wants to know, how often should people with MS get the pneumonia vaccines?
So most of the pneumonia vaccines, pneumovaxes, are a one-time deal. So the good news is generally, I can't remember what the primary care doc's going to recommend. I think it's 55 if I'm not mistaken, but at some point they're going to recommend some form of a pneumococcal vaccine for all of us, and it generally is good for life.
Okay, and you did speak about this a bit, but Paulette would like to know if any of the MS IV treatments interfere with COVID vaccinations.
Yeah, I think we've covered that. Again, it's really your B cell therapies. We've not seen, just for fun, we checked COVID antibodies after vaccination in some of our Tysabri patients, and they were definitely not impaired. I mean, they were quite good.
Okay. And you haven't come up for air, so you've been outstanding. We've been hitting this to you every 2 seconds. I don't have any more chats right now. Let's see if I get any more. Here we go. Okay, well, let's see. Oh, fatigue, they want to know. The one that asked about Paulette asked about the COVID vaccination, she also asked about fatigue. So
fatigue is up there in the big, I would say 3 symptoms that people with MS are affected by. Some people would say it's the most common symptom. It's a big topic. So we usually divide fatigue into just non-exertional, non-heat related fatigue, or lassitude. And then there's heat related or exertional fatigue, or nerve fiber fatigue. And there are treatment paths for both of those. My fatigue discussion with people with MS usually backs up to their sleep first. And so I always start the fatigue discussion with, how are you sleeping? If a person with MS has fragmented sleep for whatever reason, if they have sleep apnea, if they have to get up and pee every 5 minutes, if their legs are spasming, if your sleep is not normal and restorative, I'm not very excited about throwing drugs to give you energy in the daytime into that mix, because to me, again, it feels like you're revving an engine that is on an empty gas tank. So I would rather address the sleep issue in that individual before we go after the daytime fatigue. If it truly is a daytime lassitude issue, it's primary MS fatigue. We think about things like amantadine and modafinil or armodafinil, Provigil and Nuvigil, true stimulant medications like your Ritalin, Adderall type medicines. If it's more heat related or exertional fatigue, we think about dalfampridine, the name brand Empira, or the compounded version 4-aminopyridine, are things that we use there, and cooling strategies.
And let's see. Deborah would like to know what your view is on obagio for relapse remitting MS.
Obagio is a neat oral medication. I would say it's modestly effective. It's not up with the Tysabri, Ocrevus type medication, but it is an effective drug. It's super convenient. It's a once a day pill. It's probably one of the most forgiving oral medicines. If you miss a dose, the obagio has a half-life of forever. It stays in your system a long, long time. The downsides to obagio is it's not the most effective thing, but not everyone needs the biggest gun in the world. We do have to just make people aware. You can see some hair thinning. There's some blood monitoring. You can see GI upset in some people. The sneaky one with obagio that we're always on the lookout for is peripheral neuropathy. So if someone with MS comes in on obagio and they say, hey, my feet are a little more tingly or my hands are numb and tingly, there's a temptation to blame that on the MS when in fact it could be a side effect from the obagio. You usually get nerve conduction studies to sort that out. If the person does have neuropathy, that's a deal breaker. You've got to get the person off the medication.
I have a few more questions and we're just around the 4:30 mark. Do you have a couple seconds extra?
Sure.
So Karen wants to know, is there any treatment for heat intolerance other than staying cool? Or is there a treatment in research?
Yeah, so she hit it on the head though, cooling. The dalfampridine, even though we think of that as the walking drug, before there was dalfampridine, there was 4-aminopyridine. 4-aminopyridine is a non-FDA approved compounded mom and pop pharmacy drug. It has the same mechanism as dalfampridine. These are both potassium channel modulators that work on naked nerve fibers. So dalfampridine was never studied for heat sensitivity. We always thought of 4-aminopyridine as something that potentially worked for heat sensitivity. So as you raise your core body temperature, you're sort of pointing out the weak spots in the electrical conduction chain. So areas of demyelination stop working when you raise your core body temperature. In some people, we can have you tolerate heat better with 4-aminopyridine. It works in about 40% of people with MS that try it. We do have people that use it seasonally. They'll start it, depending upon where you live. Here in Georgia, people might start it in March or April, continue it on through October or so, give themselves a break in the cooler months. So that as a medication, that's really our only game that we've got right now.
Okay. Sharon has a question. She said she's been on a max dose of baclofen, 20 milligrams 5 times a day. It's not cutting it. And she said, I'm now incorporating dantrolene. What's your thoughts on dantrolene?
Dantrolene is certainly a good option to look at. It does work for some of our folks. I can't explain why it doesn't work for more of our individuals. So, we refer folks here at Shepherd Center across the hall to our multi-specialty clinic, where they're also working with spinal cord injured or people with traumatic brain injury issues. Dantrolene works really well in spinal cord injury. It works pretty well in traumatic brain injury. It works less well in people with MS, but it's still worth a try because when it works, it's great. Other things, tizanidine can be added to the baclofen, and then we talked earlier about cannabinoids or cannabis products or certainly something that we can add into the mix.
Great. And before I thank you, I want you to know that Sharon wrote that she's thanking you for taking the time to answer these kinds of questions, and it was a great session. So
thank you all, and I appreciate you joining in.
Really, you are the Energizer Bunny.
No problem.
I didn't give you really more than 3 seconds in between. I don't even think I gave you that. So you did a fabulous job, Dr. Thrower. Thank you so much. That's really all the time we have for now. If you've missed any part of this conference, it'll be replayed on msfocusradio.org and available on demand on our MS Focus SoundCloud page or our YouTube page. Remember to follow MS Focus on Facebook, Twitter, and Instagram for times and access information. Our next teleconference will be this coming Monday, August 16th at 6:00 p.m. Eastern Time. Our speaker will be Terry Schreiner, MD. She's a neurologist who specializes in pediatric MS. Her topic will be managing pediatric onset MS with lifestyle, medications, and teamwork. Our sincere thanks to all of our attendees for your participation, and especially Dr. Thrower, who was kind enough to answer every one of your questions today. Have a great day, everyone, and we hope to see you again soon.
Take
Bye-bye.
care, everybody.